Good afternoon. My paper is on observational study on the proportion of retinopathy of prematurity and its clinical cause. ROP is a disease of retinal vascular and capillary proliferation affecting preterm infants. It is a potentially blinding disease if not diagnosed and treated early. Incidence of ROPs have been increasing in developing countries over the past 2 decades with advancement in neonatal care. There are several risk factors, including maternal and infant factors, which contribute to the development of ROP. ROP diagnosed infants have to be followed up regularly for progression and regression, and treatment is given according to National Neonatology Forum 2020 guideline. Most of the ROPs usually regress with complete development and development of retinal vasculature. Here in my study, my objective is to find the proportion of ROP and to assess the clinical cause among ROP detected infants. It is a prospective observational study done in the Department of Ophthalmology, Government Medical College, Kottayam, during a period of 12 months after getting approval from Institutional Review Board in a population of preterm newborns presenting to the Department of Ophthalmology who satisfied the inclusion criteria, who satisfied the National Neonatology Forum 2022 guideline. Those infants who lost to follow-up during study period without development of ROP or before complete vascularization of retina were excluded, and those having media opacities due to congenital anomalies like congenital glaucoma, congenital cataract, retinoblastoma were also excluded. 140 infants who satisfied the National Neonatology Forum 2020 guidelines were screened. Informations were collected through structured performa. Anterior segment and pupillary examination was done. Fundus examination was done under topical anesthesia and with phenylephrine tropicamide combination eye drop. Using a Flens-Creel depressor used to visualize the retinal periphery, and complete fundus examination was done using indirect ophthalmoscope and 20D lens. ROP detected infants were classified based on ICROP guideline. Follow-up examination was done up to complete vascularization of retina of both eyes of the infant. Coming to the results of my study, out of 140 infants screened, 35 infants, that is 25%, had ROP. 2 newborns, that is with 4 eyes, had sluggish pupillary reaction with poor pupillary dilatation, had stage 3 ROP with plus disease in the initial presentation itself. ROP detected eyes in the initial presentation. 18.6% had normal fundal finding, 42.9% in stage 1, 27.1% in stage 2, 10% in stage 3, none presented in stage 4 or stage 5, and 1 eye, that is 1.4% presented with AP-ROP. Most of the ROP detected infants belong to stage 1 in the initial presentation, none presented with stage 4 or 5, 1 baby presented with AP-ROP disease. Plus disease was present in 2.1%, that is 3 eyes. ROP was commonly seen in zone 2 in my study. Most of the babies detected with ROP belong to 28 to 32 weeks of gestation. Most of the babies presented for screening belong to birth weight between 1500 and 2000, and ROP was detected in babies having birth weight between 1000 and 1500. There is no statistically significant difference between male and female gender in ROP detected infants. Coming to the risk factors in ROP detected infants, we studied multiple gestation, pregnancy-induced hypertension, gestational diabetes mellitus, respiratory distress syndrome, congenital heart disease, bradycardia, interventricular hemorrhage, sepsis, anemia, and apnea. Of these, only RDS and sepsis showed a statistically significant association. These are elaborated separately. Of the ROP diagnosed infants, 4 eyes remained normal till the last follow-up. None of the infants presented with stage 4 or 5. Infants with AP-ROP was treated with anti-VEGF and laser once diagnosed. All the ROP detected eyes showed regression from the second visit itself. On the final follow-up, ROP was regressed in all the ROP diagnosed eyes. Treatment given for ROP detected infants. 4 infants belonged to stage 3 zone 2 were treated with laser. 1 infant with AP-ROP treated with anti-VEGF and laser. Coming to discussion, 49 out of 118 babies had ROP in Bhavanahangi et al. Study, which is 41.5%, whereas urban study by Sudha Chowdhury et al. Had 22.3%, which was similar to my study. Most of the babies presented with stage 1 in my study, whereas Anand Vinikar et al. Study had more proportion in stage 3. My study babies were presented with zone 2, which was similar to Anand Vinikar et al. Study. Most of the ROP detected babies fell into a gestational age of 20 to 32 weeks. Newborns with severe ROP belong to less than 28 weeks of gestation. In our study, most of ROP and severe stages occurred in less mature, lower birth weight infant. RDS is a major risk factor associated with the ROP in my study, which was similar to Anandvenika et al. Study from South India. In my study, sepsis was found to be statistically significant, which was similar to Hakim et al. Study. Those neonate with sluggish pupillary response and poor dilatation to mid-radiatics found to have stage 3 ROP with plus disease at time of presentation. Conclusion. My study has concluded that proportion of ROP among preterm newborns is 25% for any stage. There is significant association with RDS and ROP. Serial follow-up of preterm newborns help to detect ROP early. All ROP detected infants on follow-up showed regression by its own or with treatment. These are my references. Thank you.
So you are told zone 2 ROP.
Yes, sir.
Which stage? Which stage is more commonly seen?
Stage 3, sir.
Stage 3. Plus or without plus?
Without plus.
Did you give treatment or not?
Those one baby with AP ROP we have given.
No, I'm asking you stage 3 in zone 2. Did you give treatment or not?
Yes, sir.
Give treatment.
Yes, sir.
What the ETROP study report says? Did you follow ETROP study reports?
Yes, sir.
Then? See, ETROP says zone 2, stage 3 alone you can observe. 3 plus you have to give treatment. This is what ETROP study report says. I do not know, but did you give anti-VEGF also these patients?
Those with AP ROP stage 3 with plus
zone,
disease we have
2.
given.
3 plus.
Yes.
Okay.
Okay, ma. You also mentioned in your title as retinopathy. Basically, don't use abbreviations too much, like CVI, you know. In any study, only the classical abbreviations like DNA, RNA, which are universally accepted, will be taken. That's okay, but it's a good presentation. You said 140 have been screened.
Yes, sir.
No, how many did you screen? How much was the follow-up? That is more important, no? In any ROP. What was the follow-up rate? How many totally you screened?
140 preterm infants we were screened. Out of that, 35 had ROP.
No. How many you screened and how many did not turn for follow-up? You told no exclusion criteria. If they don't come for follow-up, it was left out of the study.
Yes,
No, what I am interested is what is the fallout rate? Initially, you would have screened 190, 180, out of which 30 would not have come for. Isn't it correct?
As, out of 140, only 35 we had correct follow-up, sir.
Oh, the whole data is only for 35 people.
Yes, sir. 35.
But you were telling N is 140 in some of your slides.
140 we were screened. Out of that, 35 had ROP.
Only 18% you said no finding in the first visit.
Sir.
Just check on it. So if the N is 35, then all data will change.
Infants we had 35 and in eyes 70 eyes. So some babies had ROP in one eye, some had didn't have ROP.
So you said 140 eyes, huh?
140 infants.
Infants. So the eyes will be more.
280.
Somewhere there is some. I'm not sure whether I'm able to follow, but I hope you understand.
Yes.
The N is different from what you are trying to say as 140.
Yes.
Correct.
Yes.
Okay, ma. Thank you. Good presentation.